Good evening, everybody. Today I am welcoming you all to our ASN VSA's webinar. Today our topic is Irritable Bowel Syndrome. It is going to be delivered by Dr. Prashant Bhandarkar sir, who is a renowned gastroenterologist from Nagpur. I request our President Dr. Vikram Desai sir to welcome Dr. Bhandarkar sir.
Hello.
Hello.
Hello sir, we can hear you.
Yeah, good evening, everybody. Good evening, Prashant. Welcome to this webinar.
Good evening, Vikram. Good evening, everyone.
Yeah, today we have a nice topic, very intriguing one. And I think the incidence is going up day by day. So clinical evaluation and management of IBS or irritable bowel syndrome. And we have none other than the local stalwart, Dr. Prashant Bhandarkar, renowned gastroenterologist of the city and the region, who will deliver his talk on IBS. So before we start with the proceedings, I would like to make an announcement. We had our ASN website launched a few days back, and our local edition of the surgical magazine that is called Upsurge. So we have launched it in an e-fashion on the online platform last week. So we had a crossword puzzle in it, I web cross, and we had invited answers from our audience. And the winners of the audience of the IPROS poll are there ready with me now. And I'm glad to announce the names of the following two winners of this crossword puzzle I web cross, Dr. Girish Miraskar and Dr. Neha Outsar. So congratulations, both of you. You will receive a token of appreciation from ASN. And now I hand over the mic to Atish and Yogesh to conduct the further proceedings.
Yeah, Yogesh. Yogesh, are you there?
Yes, sir. Yes, sir.
Yogesh, please, with your permission, should we request Dr. Bhandarkar sir to start it?
We have Savalake sir in attendees, I guess. If you can unmute his mic for a minute.
Mic.
Let him give the broad perspective over the topic, and then we can start.
Yeah. Neeraj sir, unmute your mic, please. Neeraj Savalake sir, please unmute your mic. Savalake sir, please unmute your mic. I unmute. Yeah. Welcome, Savalake sir.
Thank you very much, Dr. Atish.
Neeraj sir, please introduce the topic, and then we may start our webinar, today's webinar.
Okay. Thanks a lot, Dr. Atish. And good evening, Bhandarkar sir.
Good evening, Neeraj. Nice to hear your voice.
Same here, sir. I will be introducing my senior Dr. Prashant Bhandarkar sir. In fact, he does not need any introduction. Everyone in Nagpur as well as around know him. He's a brilliant academician, and he has to his name many articles in published in national and international journals, and it's a very good teacher too. He likes teaching a lot and giving a lot of such good talks all over that are quite enlightening. So today, without wasting any time, I will ask Bhandarkar sir to proceed with an interesting topic, which is form the bulk of our gastro OPD. So I request Dr. Bhandarkar sir to please proceed with the talkings.
Yeah. Thank you, Neeraj, for those kind words. It's indeed an honor to have you as our chairperson. At the outset, I would like to thank Association of Surgeons of Nagpur, especially President Dr. Vikram Desai, then my good friends Dr. Yogesh Bang, Atish Bansod, and it's been a great honor to have this talk this evening. So I'll be discussing about irritable bowel syndrome. As Neeraj rightly pointed out, so almost 30 to 40% of patients attending a gastroenterologist's OPD are actually irritable bowel syndrome. That is the magnitude of the problem. So we shall be learning about the aspects of epidemiology, pathophysiology, diagnosis, and treatment this evening. It's a common GI disorder. Before coming to the formal definition, let me just introduce that IBS is characterized by recurrent abdominal pain, discomfort, a lot of times bloating, and some stool irregularities. Compare this with dyspepsia, where the pain is related to food. Here, the pain and discomfort is related to change in bowel habits. It could be constipation and or diarrhea. Affects 10 to 20% of the population. We have some more figures about the epidemiology. So it affects 9 to 23% of population across the world. As I said, there are subtypes. We'll see them in detail later. There are a lot of associations. IBS is many times you see other diseases or disorders in the same patient: fibromyalgia, chronic fatigue syndrome, gastroesophageal reflux disease, functional dyspepsia. A lot of times our diagnosis at the end of history taking is IBS dyspepsia, IBS GERD, and so on. And a significant psychiatric disorder is found in these patients: depression, anxiety, and somatization. I thought this specifically put this slide because when we were doing our MBBS and still a common practice with a lot of family physicians to label a patient as chronic amoebiasis. This was because of the presence of amoebiasis in stools of patients with chronic lower GI symptoms, and creates confusion among physicians, and they often label these patients as having chronic non-dysenteric amoebic colitis. A study from India in the past showed that 24% of patients treated with metronidazole they experienced temporary improvement. So specifically, we have two studies which explored this issue. So this important study, no significant differences were found in the proportion of amoeba in the stools of controls and IBS patients. So amoeba 18 and 18%. Serology for amoeba, again similar percent in IBS and controls. Colonoscopic abnormalities similar percentage, and histological abnormalities also similar percentages. Let us not go into the detail of histological abnormalities, but again, more importantly, no significant differences in response to therapeutic trial with metronidazole among patients who were cyst positive or negative at 6 months. In another study of 154 inmates of leprosy habilitation, they found amoeba in IBS patients 50% and in controls 90%. However, most of these were non-pathogenic amoebas, and there was no relationship between detection of amoeba and symptoms of IBS at 12-month follow-up. So these studies suggest that non-pathogenic amoeba is an innocent bystander in IBS subjects, or cyst passers are there could be cyst passers which are inappropriately termed as chronic amoebiasis and often treated with anti-amoebic drugs unnecessarily. Some of them, these patients may actually have say giardiasis, or maybe have some other bacterial overgrowth, and that might respond temporarily to metronidazole. Metronidazole typically also increases the stool bulk, so that can have a kind of a beneficial effect or a satisfactory effect for some patients for some time. We got a lot of studies from India and South Asia, so let us concentrate on the Indian studies. So we had a study from KM Hospital in 2001. The prevalence was 7.5%. The criteria used for diagnosis, we will come to that shortly. While in Haryana it was 4%. So in India the prevalence seems to be varying from 4% to 7.5% compared to West, where it is typically around 10 to 12%. Again, a male-female ratio, most studies from West tell us that females are more predominantly affected, while in most Indian studies, South Asian studies, Sri Lanka, and so on, more or less equal ratio of males and females, or maybe slightly more male preponderance, and even that may be because of the woman may not be going frequently to the doctors. In fact, almost 30% of IBS goes unreported. This is an important chart which feels a bit yucky. but then it is has got a lot of application for treatment, a lot of application for research. The stool form of a person can be divided into these 7 types. So the more healthy is the middle form, type 3 and 4. The type 1 and type 2 are constipated stools, where separate hard lumps. Type 2 are sausage shaped but lumpy. These 2 are difficult to pass, so a lot of straining might be required. These 3 are more associated with a slightly better and physiological stool form. Especially 6 and 7 are associated with diarrhea. So they are loose kind of stools. So what is the importance? We'll see to that. This importance comes in subtyping of irritable bowel syndrome. We saw that irritable bowel syndrome is a disorder characterized by abdominal pain and some disorder of the stools. It could be change in consistency of the stool. It could be change in frequency of the stool. Depending on whether, so patient may have diarrhea or constipation. Depending on the predominant stool pattern, patients are divided into IBS-C, IBS constipation predominant, IBS-D, diarrhea predominant, mixed, and undeterminate. What happens in IBS constipation variety, that more than 25% of stool belong to the constipated variety, type 1 and 2. Type 1 and 2. So most of the times, more than 25% of the times, the patient has got constipated stools, and less than 25% it is loose stools. In IBS-D, it is reverse. More than 25% are the loose stools, type 6 and 7. But also less than 25% are constipated stools. In IBS mixed, both sometimes the stool are constipated variety, sometimes the stool are loose variety, and each time the total frequency is more than 25% of these stools. So 25% of these stools could be type 1 and 2, and 25% of these stools could be type 6 and 7. So that's a mix. And when you cannot put the patient into C, D, or M category, you call it as IBS undeterminate. So that is it. This is the 25% cutoff. Type 1 and 2 is constipated variety. Type 6 and 7 is diarrhea predominant. Both mixture of 1, 2, 6, 7 is mixed, and rest is undeterminate. So of all the 100 patients you might see of IBS, you would have about 17% who have constipation predominant, 32% would have diarrhea predominant. Mixed pattern is most common, as you can see. So alternate constipation and diarrhea, or sometimes constipation, sometimes diarrhea, sometimes even normal stools. And undeterminate is very low. I would briefly discuss about the pathophysiology of IBS. The question in the mind of treating physicians and surgeons would be, why should we know the pathophysiology apart from just the theoretical aspect? See, we have a tendency to call IBS patient that अरे तुम साइको हो, तुमको कुछ प्रॉब्लम ही नहीं है, and then that creates a very negative impact on the mind of the patient. If you tell him that all his symptoms are psychological, but instead if you give him the real reason or the pathophysiologic mechanism of why he is experiencing bowel symptoms, and they are genuine symptoms, mind you, they're not imaginary symptoms or malingering or unnecessary complaint. They're true, genuine, troublesome symptoms. And that is why if you give the patient a pathophysiologic basis to his symptom, then he is very satisfied, and that establishes a good doctor-patient relationship and goes a long way in a therapeutic response. So there are various things which will come to one by one. So sensory dysfunction is described, called as visceral hypersensitivity. Motor dysfunction in the gut is described. There could be hypermotility or hypomotility, whatever you like to call. There could be inflammation in the gut which produces such symptoms. There could be altered intestinal microbiota. But very important is this altered brain-gut axis. That also we'll see. So just to summarize in a tabular form, there could be visceral hyperreactivity either because of hypersensitivity or hypermotor response. There could be mucosal inflammation. A bacterial overgrowth is at times contemplated to be involved in the pathogenesis. There could be altered fecal flora. Everything contributes to what is called as a hyperarousal state, both in the tummy, body, and both in the mind, and that is the body-mind interactions. So of late, especially a type of IBS called as IBS-post infectious, where inflammation of the gut, apart from the hypersensitivity and hyperreactivity, which was the basic and previous understanding, inflammation is of late has been implicated, and we have seen upgraded mast cells, mediators of inflammation. The gut mucosa becomes sensitized to stimuli, maybe as a result of inflammation and sometimes infection. And the other factors which may be responsible for sensitizing the mucosa to normal stimuli could be bile acid, could be sometimes say operation in the past, laparotomy, hysterectomy, food. So just something more about post-infectious IBS. 1 in 10 patients with IBS began with infectious-like symptoms. So they might have had, they had an attack of fever, loose motions, and vomiting. So typical gastroenteritis. Not all patients with gastroenteritis ultimately develop IBS. So about 3 to 36% according to various studies. There are certain risk factors. If the initial attack of gastroenteritis was particularly severe and long duration, with particularly toxic infecting bacteria, depending on the strain, that could be, and maybe if the patient required hospitalization, it was so severe. So these are the patients who are more likely to develop what is called as the post-infectious IBS. So the infection goes away, but the inflammation persists, and that inflammation gives rise to hypersensitivity and hyperreactivity. So underlying female gender are more predisposed to post-infectious IBS, and underlying psychological state of the patient. So patients who are depressed, hypochondriac, and have adverse life events in the past 3 months, if they develop gastroenteritis, they are more likely to develop post-infectious IBS. So that is just the summary. We can skip that. So what does the infection and immune system do to the gut? It alters the gut transit, it increases rectal sensitivity, increases intestinal permeability, and it probably causes serotonin dysregulation. And that's why you see in the treatment of IBS, there are a lot of 5-HT3 antagonists and agonists which are used. So serotonin dysregulation might be occurring. Bacterial overgrowth is a controversial topic. Whether it really causes IBS, we do not know. But some part of the inflammation which is seen in patients with IBS might be because of a low-grade bacterial overgrowth, which is not to the level of being able to diagnose as SIBO. SIBO is a specific diagnosis which is with a specific diagnostic criteria, but a low-grade SIBO, small intestinal bacterial overgrowth, might be contributing to inflammation and hyperreactivity, but the theory is not yet proven. Whether hereditary plays a role in irritable bowel syndrome. There has been again conflicting studies between monozygotic and dizygotic twins. Maybe it does play, but more important, why do we find IBS running in families? Maybe because of the subconscious mimicking of the symptoms between family members. So the mother might take the bowel pattern of her, the daughter might take the bowel pattern of her mother, and the son might take the bowel pattern of his father. So it's more of a subconscious mimicking and may not be true heredity. And again, coming back to what I introduced some time back, is a brain-gut interaction. Because why this came into picture, into discussion, it was seen that psychosocial factors appear to be important in IBS. Anxiety, depression are common. Abuse in childhood or adulthood is associated with IBS. And brains of people who are normal, controls, they are better able to suppress pain. While IBS patient perceive pain in an excessive form at the level of brain. So what is this brain-gut axis? It's a bidirectional signaling pathway between CNS and the ENS, enteric nervous system. The enteric nervous system is a highly evolved nervous system which finally controls the sensory and motor functions of the gut. These signaling pathways are regulated at neural, hormonal, and immunological levels. This is how it goes. So there is a CNS. We all know what is that. Enteric nervous system, which is present in the myenteric plexus and submucous plexus, is a complex network of nerves and neurons, nervous system. So there is a communication, two-way communication. Then there are some intermediate cell, and then finally the effector system, which is the muscle, which is the sensory endothelium and the endocrine cells and vasculature. So ENS and CNS are connected through the parasympathetic and sympathetic pathway. So this is a very complex pathway with the to and fro traffic. So I typically like to tell my patient that there is a to and fro traffic, and there could be many possibilities of short circuit. So central to peripheral communication, Mumbai to Delhi, Delhi to Mumbai, there could be miscommunication and so on, and they find it very interesting to and appreciate the pathophysiology. So that is the brain-gut axis. So ENS controls motility, exocrine, endocrine secretions, reflex activity, neuropeptide release, and so on, and microcirculation of the gut. So this dysregulation of brain-gut axis can cause altered motility and altered sensitivity. Actually, dysregulation of brain-gut axis is seen in many disorders like stress, anxiety, depression. So another basis, another importance to discuss this brain-gut axis is because in IBS, perhaps you need to tackle both the brain and the gut. So treatment has to be addressed to gut as well as brain for overall improvement in IBS patients. Another basis or another relevance of brain-gut axis is a clinical observation that what is the impact of IBS on life events on IBS. So it has been seen that if patients who have a sense of loss or injustice being done to them, some event which threatens their identity, sexual or physical abuse, especially in childhood, even a positive event like marriage or childbirth, whenever there is a difficulty in coping with these kinds of stress, it might lead to irritable bowel syndrome because of some abnormalities in the brain to gut axis. That is all about the pathophysiology I wanted to discuss. This forms the basis for a good personal interpersonal relationship between patient and the doctor. Then we come to the diagnosis and clinical manifestations. I told you in the beginning that IBS is divided into diarrhea, constipation, and mixed type, and so on. And I told you about the prevalence in how it varies from 4% to 10% in India and 10 to 20% in the West. How do they diagnose this irritable bowel syndrome in community and especially in during clinical research, and so that there is a uniformity of what we talk, what two researchers talks or what two doctors talk of what they mean by IBS. That's why ever since 1979 the diagnostic criteria have been evolved, and the first among this was the Manning criteria, which was evolved in 1979. Then came the Rome 1, Rome 2, Rome 3, and today we go by what is the Rome 4 criteria. We'll see that in a short while. Right, Manning, 1978, defined as symptoms given below. What is not defined in Manning criteria is no duration is described of the symptom. And the number of symptoms may be 3 out of these. So what did Manning describe? Abdominal pain relieved by defecation, or discomfort relieved by defecation. More frequent stools with onset of pain. As pain is experienced by the patient goes to defecation more frequently. Looser stools with onset of pain. The stools tend to become loose. Mucus per rectum is an important criterion in Manning's. A sense of incomplete evacuation of stools, which is a very, very common symptoms in especially in Indian population. and abdominal distension. So out of these 6, maybe any 2 or 3 were present, and they were the Manning criteria sufficient for diagnosis of IBS. Even today, these criteria are not totally obsolete. Some studies do use this. Why? I will come to that shortly. Then came the Rome 3, Rome 2 we can skip. Rome 3, they were there for almost 10 years. So they defined IBS as recurrent abdominal pain or discomfort. Again, please pay attention. There could be pain or discomfort 3 days per month in last 3 months. And what is this pain? This pain should improve with defecation. Okay, it improves with defecation. As there is pain, there is change in frequency of stool and change in form of stool. So along with pain, there is the patient may have a constipation or diarrhea, change in frequency, and change in form, loose or hard. And diagnostic criteria to be fulfilled for last 3 months, and the first symptom should have been started 6 months back. Bit heavy for surgeons, I know, but I'm sure you'll bear with me, and you'll be happy to learn about this at the end of the talk, because these have to be used in clinical practice. Then came the Rome 4, recurrent abdominal pain for at least 1 day a week. So that was 3 times in a month. Rome 3, this is 1 day a week, and it is related to defecation, not necessarily improved by defecation or worsened by defecation, and associated with change in frequency of stool, change in form. This again is like the previous Rome 3, and symptoms again started 6 months ago. So what is the difference between Rome 3 and Rome 4 criteria? Here Rome 3, 3 days in a month, here at least once in a week, so maybe 4 times in a month. Here the pain should improve with defecation. In Rome 3, they may change it because they knew, they realized that pain does not necessarily improve. So there is pain, patient goes for defecation. It may worsen also, not necessarily improve, as told in Rome 3. Onset associated with change of frequency. So as soon as there is pain, the patient will have constipation, diarrhea, or change in frequency. That was the requirement in Rome 3. In Rome 4, they say that there is association. May not be before pain or during pain or after pain. It could be just same day association, or during that period it is associated. So that is the difference between Rome 3 and Rome 4. Pros and cons. Rome 4 mentioned that pain can be anywhere. So this is good, because in Rome 3 it was lower abdominal pain. Bloating is a common symptom which is removed in Rome 4. And Rome 4 necessarily wants pain in abdomen. Now there is a problem. That's why I told you why Manning criteria and Rome 3 criteria cannot be called as obsolete, even when the modern Rome 4 criteria have come. Because Rome 4 criteria, it is believed that cannot be accepted or applied in Indian population. Pain is present only in 70% of Indian population who have other typical IBS criteria present. A lot of these patients do have bloating, which is not present in Rome 4 definition. A lot of these patients have mucus in stools, which is not present. So that's why studies in India still use sometimes Manning or Rome 3 criteria. So I already told you that Indians may be different, and Rome 4. So that's why there's been an Asia Pacific definition also. I think we did not go into that, but we should understand that Rome 4 may not be applicable all the time in Indian scenario. Then we come to the clinical situation. So as soon as the patient is seen by you in the OPD, you start suspecting IBS whenever there is pain and association of the pain with bowel. Most important is whether the patient, IBS is the diagnosis of exclusion, because same symptoms can be seen in inflammatory bowel disease, can be seen in colon cancer, and that's why medical history serves to identify clinical manifestation as well as other possible causes of similar symptoms. We should use the Bristol scale to record the stool consistency whenever there is a problem of diarrhea or constipation, and try to categorize between the various types. A thorough history with particular attention to organic disease like IBD and colon cancer. We should always try to take history of medicines. A lot of medicines used in modern allopathic practice can cause diarrhea, can cause constipation. So the symptoms may be just drug related. You should take family history to rule out IBD, colorectal cancer, and celiac disease. Physical examination is usually normal in IBS. However, there could be mild left iliac tenderness. This is a long list of drugs which can cause diarrhea. There are antiarrhythmics, antihypertensives, diuretics, anxiety drugs. There's a big list. I mean, you can just check it on the net. And similarly, a lot of allopathic medicines cause constipation. So we have to be very cautious that drug-induced diarrhea and drug-induced constipation cannot be overemphasized. But as I said, that IBS symptoms can be seen in organic disorders. IBS is a functional disorder where all investigations tend to be normal, like stool test, routine biochemistry, colonoscopy, malabsorption test, CT scan, everything will be normal. So it's, in a way, it's a diagnosis of exclusion. You have to exclude organic causes. But there are certain features which, if you see the patient in OPD, you should be alarmed, and these are called as alarm symptoms of in IBS, where you should not first consider IBS, but first consider organic etiology. Onset in old age. IBS is typically disease of young age. Old 50 is not old, but the criteria is more than 50. If the presentation for the first time, try to older age, I can say older than 30 to 50 maybe. So if there is progressive deterioration in patient's clinical status, fever, progressive unexplained weight loss, bleeding, whether it be bleeding, PR or melena, steatorrhea, if the patient presents in a dehydrated condition, if the diarrhea is nocturnal, if the abdominal pain is unrelenting, relentless, progressive abdominal pain, laboratory abnormalities like iron deficiency, anemia, elevated C-reactive protein, fecal calprotectin, lactoferrin, and so on. And if there is a family history of inflammatory bowel disease or colorectal cancer. So whenever such type of symptoms are seen with pain in abdomen and alteration on bowels, which are also seen in IBS, you should be more cautious in ruling out organic cause and not just label it as functional irritable bowel syndrome. So we should investigate patients. What are the investigations? In all patients, we should have a complete hemogram, a stool examination, at least a proctoscopy, if not sigmoidoscopy. Sigmoidoscopy is ideal because 95% of ulcerative colitis involves the rectum. So a proctosigmoidoscopy will rule out ulcerative colitis in almost 90 to 95%. However, depending on what is the predominant symptom, you may try on adding other tests in order to exclude organic etiology. For example, if the patient has malabsorption, you know, if there's iron deficiency, anemia, or low albumin, you cannot label at IBS, at least in the first go. So you should do fecal fat, serum B12 levels, plasma ferritins, and you should test for celiac sprue if malabsorption is there. Relentless diarrhea can be seen in presence of giardiasis. Amoebic dysentery is more obvious actually. Diarrhea predominant IBS, if persistent or severe, you should do fecal calprotectin. What is the role of fecal calprotectin? Is available for us in here in Nagpur. So level of more than 50 microgram at a sensitivity and specificity for 81 and 87% sensitivity and specificity. So a low fecal calprotectin will exclude IBS, and a high fecal calprotectin above a threshold level of 50 will point to a possibility of IBD, inflammatory bowel disease, wherein you will like to do a colonoscopy. Of course, barium will follow through if you're postulating other organic causes like intestinal tuberculosis and so on. Lactose intolerance test if you suspect lactose intolerance in your patient. For a patient who are heavily constipated, but otherwise in good health, no alarm symptoms, you may have to do colonic transit studies, you may have to do anorectal function test, and of course appropriate age appropriate screening for colorectal cancer. So there are no clear recommendations in the Indian society, but in the West we have got standard recommendations when to do fecal local blood, when to do colonoscopy. But even in Indian scenario, we should be cautious that we should not be missing on colorectal cancer, and especially if there is a family history and other alarm symptoms, you may like to do a colonoscopy. So what is the differential diagnosis of IBS? In diarrhea predominant IBS, we would like to exclude celiac disease, microscopic colitis, small intestinal bacterial overgrowth, and IBD, inflammatory bowel disease, ulcerative colitis, or Crohn's. Constipation may be secondary to organic diseases like colorectal cancer or obstruction, dysenergic defecation, or slow colonic transit. Either clinically or after investigations, you should rule out all organic causes and then reach a diagnosis. And of course, you should try to apply the criteria, some criteria, Manning or Rome 3 or Rome 4, and you should. So what is the outcome of irritable bowel syndrome? Most patients with IBS have chronic symptoms that vary in severity over time. A systematic review showed that 2 to 5% of patients were diagnosed. They were followed for a period of 6 months to 6 years. They had some alternative GI diagnosis at follow. Symptoms remained unchanged in 30 to 50% and progressed in 2 to 18%. Improvement in 12 to 38%. The IBS subtype also may change. So almost half of the patient with IBS remain unchanged or progress. So it's a chronic disease and remitting and relapsing disease. So we come to the final aspect of my talk, which is management. What are the aspects of management we have to consider? We have to establish a categorical diagnosis, not only by exclusion, but by categorical application of Rome criteria, or maybe Manning rarely. But I think Rome 3 criteria are more relevant in our situation. Then you have to subtype according to Rome 4, whether it's constipation predominant or diarrhea predominant, because that will lead to more specific treatment after, once you subtype the IBS. What does the disorder, what impact does it have, whether it's a patient has mild to moderate symptoms or severe symptoms? So any physiological and abnormalities and psychological abnormalities which are associated in your given patient. Patient education remains the cornerstone. Successful management relies on strong patient-doctor relationship. Reassure the patient, emphasize the expected chronicity of symptoms and periodic exacerbations. You should have discuss with the patient that they should not have very idealistic expectation. Symptoms can be ameliorated, but not eradicated, because it's a symptom complex. Finally, it's not one single disease per se. It's a conglomeration of symptoms, and symptom relief is the aim of treatment, and not just and not the eradication of IBS. So they should have realistic expectations. Reassure the patient that IBS does not lead to colon cancer, or IBS does not lead to inflammatory bowel disease. Teach the patient to acknowledge stress factors and how to tackle the stress. So the management strategy recommends a positive diagnosis with Rome criteria. What is the real patient's perspective? Developing a good doctor-patient relationship, identifying contributing factors, and then going to the treatment. Treatment in mild and intermittent symptoms that do not impair quality of life. Dietary modifications alone may be sufficient. You may not have to really use pharmacological agents. In fact, I tell my patients that this disorder is absolutely opposite of diabetes and hypertension, or for that matter IBD. So in diabetes and hypertension, patient, even if they do not have symptoms, they will have to take treatment. While in IBS, even if they have symptoms, if they can manage with just reassurance and some dietary modifications, they may not take symptoms, and in fact that goes a long way in a more positive outcome. Only if the symptoms are severe, or if they don't improve with dietary modification, then you add a pharmacological treatment. you should counsel that there is no increased risk of malignancy. Realistic expectations should be set. Involve the patient in treatment decisions. So what kind of dietary modifications can be made in patients with IBS? Patient may tell them that certain food aggravate their symptoms. So the common sense tells you that they should avoid those foods. There is insufficient evidence to support allergy testing in IBS. Certain gas producing foods which are all familiar for us: beans, onions, then carrots, alcohol, caffeine, bananas, and add to these maybe cabbage and broccoli. So these are very common gas producing food. In our context, chana, besan is and milk in a lot of our patients. So the these are simple dietary advice you should give to your patient. Then you should know of a concept called as FODMAP diet. So FODMAPs are fermentable oligo, di, and monosaccharides and polyols. This is short form is FODMAP. So there are foods which are high in FODMAP, and there are foods which are low in FODMAP. What we advise in patients with IBS, if normal gas, this normal exclusion of gas producing food doesn't work, then we can go to what is called as a formal low FODMAP diet. So these, what are these FODMAP? They are short chain carbohydrates. They are poorly absorbed and osmotically active in the intestinal lumen, where they are fermented by the colonic bacteria, and because of fermentation there is abdominal bloating and pain. And of course, in Indian patients, many times mirchi, chilies, green chilies, red chilies aggravate symptoms, and we should modify them. I mean, advise to avoid them. So just a list. This is available on the net. Fermentable oligosaccharide. What are the examples? Wheat, barley, onion, garlic. I'm just picking up the common items: cashews, legumes, chickpeas, chana. So these are oligosaccharides. Fermentable disaccharides. So everything is fermentable. Oligosaccharides, fermentable disaccharides is lactose, milk, yogurt, ice cream, and so on. Fermentable monosaccharides, they are more fructose rich. So there is a lot of fructose in them. Apples, mangoes, cherries, watermelon, and another is fermentable polyol. So all these are the fermentable: apples, cherries, watermelon, mushroom, cauliflower. So these are food to be avoided. So these are food. If you avoid this food, then it is will be called as a low FODMAP diet. So low FODMAP diet you should always give a trial of low FODMAP diet in your patients. Studies have demonstrated an improvement in IBS symptoms with FODMAP diet. We can skip this. So once dietary modification and dietary restrictions doesn't work, then you go to pharmacological treatment, and the pharmacological treatment of IBS is symptomatic. You pick up the most predominant symptoms and try to address that symptom. But unfortunately, in treatment of IBS, once you try to treat one symptom, the other symptom might get exaggerated. For example, if you try to treat diarrhea and constipation, gas bloating may be exacerbated. If you try to treat constipation, pain may be exaggerated, bloating may be exaggerated. So it's very difficult to give a complete satisfactory response. But still, there are certain guidelines. So if it's a constipation predominant, first line is fiber. Fiber supplement could be soluble fiber like xylem, or insoluble fiber like wheat bran. If fiber doesn't work, then you go to polyethylene glycol. And then you may also try lactulose. If these first line therapy do not work in constipation predominant IBS, then you go to stronger laxatives like bisacodyl, picosulfate, lubiprostone, linaclotide, and procalcipride, which is the recent one. If it's the diarrhea predominant, first line is loperamide and difenoxylate, commonly used by all of us for treatment of acute diarrhea. They also work in diarrhea predominant IBS. And second line is alocetrone, ramocetrone. Rifaximin is also used for diarrhea predominant IBS. A course of 2 weeks course of rifaximin with 550 milligram 3 times a day can be used. Bloating is the most difficult symptom to treat, can be bloating, but you may try a probiotic or antibiotic like rifaximin. Pain, sometimes just treating the pain and just treating the constipation and diarrhea might relieve the pain, but if that is not happening, then you may have to add antispasmodics and anticholinergics. So there are directly acting antispasmodics like mebeverine and pinavirium. Then there is otilonium bromide, and there are certain which act through anticholinergic pathways, which are the dicyclomine and hyoscine butyrate. So those are the antispasmodic. And finally, we come to the antidepressant. So what is the exact role of antidepressants in treatment of irritable bowel syndrome? Because of their anticholinergic effect, they are immediately useful for diarrhea predominant IBS. But since they are constipating, you should be very cautious in using them in constipation predominant IBS. Then pain. Lot of these, most of these antidepressants have got a visceral analgesic effect, which is at a dose much lower than their antidepressant action. So you will appreciate that for typically if you are using imipramine or you are using amitriptyl, the typical dose for depression is 25 milligram, 50 milligram, and 75 milligram. Whereas in patients with irritable bowel syndrome, you should start with a lower dose, 10 or 25, right? So a lot of studies are there which tell you that tricyclic antidepressants are useful in managing pain in patients with IBS. SSRI are actually do not have much the selective serotonin uptake inhibitors are also there, which are also antidepressants, but there are not many studies. Unless the patient has depression, probably you will not like to use SSRI, but you like to use only tricyclic antidepressants. So antibiotics, as I said, antibiotics may be useful if there is an overlap of SIBO. Then there was Target 1 and Target 2 trials where they use rifaximin in patients without constipation and found beneficial effect for diarrhea as well as pain and bloating. So that is about antibiotics. Antidepressants I will discuss. Peppermint oil is another kind of antispasmodic and found to be useful in relieving pain with irritable bowel syndrome. So friends, I think I'll conclude my talk, and next 25 minutes we can address to question and answers. Anything which I might have inadvertently missed, or Yogesh and Atish are particularly wanting me to address, we can take up during question and answer session. Thank you very much for your kind attention.
Thank you very much, Prashant sir, for a very elaborative talk on IBS, such a difficult topic. We routinely encounter many patients of irritable bowel syndrome, but sometimes it becomes very difficult to manage them. So I request Dr. Neeraj Sawalake sir, if he has some questions and has to give some comments, he may please give it.
Thank you, Atish. I must congratulate Bhandarkar sir. As always, he has been lucid and he has covered the entire topic, and nothing has been left unturned. So from my point of view, I have got revised again on the topic of IBS, and the lecture has been very informative, especially for the surgeons especially. because they are also seeing a lot of these patients. And sir has very lucidly explained each and every point, how to manage, how to diagnose this difficult to treat disease which lingers on and keeps on coming after a relapse and again goes into quiescence. My one question to Dr. Bhandarkar sir is, what is the routine role of calprotectin at the first instance when the patient comes to us? Should we routinely use calprotectin in means like assuring the patient that he has IBS or some other disease?
I don't think we should routinely use, because the Rome criteria and the routine stool examination and routine blood biochemistry is most of the times sufficient to make a positive diagnosis of IBS and reasonably exclude organic etiology. But only if it's severe symptoms or persistent symptoms, especially diarrhea, then you should embark upon fecal calprotectin. And a particular scenario would be routine colonoscopy may not be able to diagnose small bowel Crohn's disease. And before you embark on small bowel imaging like MR enteroclysis or small bowel enteroscopy, maybe fecal calprotectin can serve as a screening test for us.
Thank you, sir.
Desai sir, are you there? Vikram sir. Desai sir. Prashant sir, I want to ask you a question from my side. What are your indications of doing a colonoscopy in patients of suspected IBS? In which cases would you prefer to do a colonoscopy?
So just two specific situations is when it's a diarrhea predominant IBS not responding, and it's progressive. And second,
excellent evaluation and management of IBS, Prashant. Congrats.
Yeah.
Sir, Bhandarkar sir, please continue.
Yeah, I'll answer this question. So specifically, if you are suspecting IBD and you want to exclude colorectal cancer, these are the two situations. And in our, I'm sorry, but I should have put intestinal tuberculosis as a close differential of inflammatory bowel disease. Actually, it comes as a though a separate disease entity, but it's like a shadow of IBD. So intestinal tuberculosis is also, if it's a consideration, then you should do a colonoscopy. And of course, we saw the alarm symptoms of in irritable bowel syndrome: age more than 50, weight loss, nocturnal diarrhea, blood in stools, melena, or hemogram which shows iron deficiency, anemia, or if there is a suggestion of malabsorption syndrome like B12 deficiency or low albumin and so on.
Okay, sir. Thank you. Over to you, Desai sir. Desai sir.
Prashant sir, I have a question.
Yeah, Yogesh, go ahead.
Sir, at what stage in your clinical management you refer the patient to psychiatrist, IBS patient to psychiatrist?
I can start off by telling the percentage of patients I would refer to psychiatrist is less than 5%.
Less than 5%.
Yeah, less than 5%. And only if they, I have tried everything. Tricyclic antidepressants, we as physicians and surgeons should be using. It's not the role of psychiatrists to use these. And as I said, these patients are in quote, they are not psycho. If you talk to them, reassure to them, and relieve their GI symptoms, help them handle their GI symptoms. As I said, most of the times you are not required to send them to psychiatrists. But actually, if there is associated clear-cut depression or anxiety disorder, you can identify during the course of your consultation, or your every counseling, every dietary modification, all pharmacological treatment has failed. and you are certain that this is not organic problem, then you refer to a psychiatrist.
Yeah, understood.
Yogesh. Hello.
Yes, sir. Neeraj.
I want to add to something what Bhandarkar sir had said. He has rightly pointed out. Basically, when the
Yeah.
patient comes to us, we should always inquire regarding the socio-psychological aspect of the patient's history. Many times you get some feud in the family or some loss in the background, and sending to psychiatrist right at the outset would put a lot of taboo on the patient also. And
Yeah,
this
no, not right immediately, not on the first consultation, sir. At what stage, like the patient is not responding to any of the treatment, he has come for third or fourth time. We have counseled from our side a lot about all the anxiety issues which the patient has and all. Then should we involve a psychiatrist? That's what my worry was. Like we have young patients who are exam going, or they are like the IT people who are already lot of they are actually stressed. IT people, we feel that their life is too cool, but then they are actually stressed people. We get a lot many IBD patients from IT industry. These patients have some bloating issues, some acidity issues, some constipation, diarrhea issues. So most of them respond to more the medications and the lifestyle modification which we say. But if the third and fourth visit is coming up in 2 months, then should we think of asking them to have a consult? That's what my question was.
frankly speaking, till date, I have only one or two patients, as Bhandarkar sir said, had pointed out, that unless and until there is a definite evidence of some major psychosocial problem or any psychosis, that is obviously evident from the patient's history. I don't know, but I have not sent only one or two patients who had some underlying psychological comorbid condition, and they have come to me as a gastrointestinal consultation as for second thing, not the means like the primary. So I don't think so we can manage them even third, or as sir has said, most of these patients, they migrate from one form of the this phenotypic IBS from to the other type. Maybe if you really get relief by pain, they will present with bloating and vice versa. So that
They
is one
migrate from
scenario where the patient
gastroenterologist
will.
to gastroenterologist also, sir.
Yeah,
They
I was
migrate
about
from
to
doctor.
Yes.
Yeah.
So Yogesh, just to conclude this particular aspect, if you spend sufficient time with the patient, which can be difficult sometimes for a busy practitioner. If you can spend at least 5 minutes and give them a good pathophysiologic basis for their symptom, then they go home more satisfied. That they know that they are having something really wrong inside the tummy and not just in the mind. And if you spend more time, and as you rightly pointed out, most of the times they leave you if they're not getting any relief. So rather than going to psychiatrist, they see another gastroenterologist, especially if the gastroenterologist is new in the town.
Yes.
Congratulations, Prashant, on a wonderful presentation on IBS. I understand it is basically a medical disease managed with drugs and basically diet modification. So my query is, at what point of time, if at all necessary, or in which subtype of patients of IBS, you will require a surgical evaluation?
Thank you, Vikram, for your kind words of appreciation. Surgical evaluation is necessary if we have during the course of excluding an organic problem, you come across a thing which needs surgical intervention. Say if we see a colorectal cancer, or if we see in the differential diagnosis of IBS, as you see, only colorectal cancer probably needs a surgical assessment. Otherwise, things like IBD, mostly a medical management is there, microscopic colitis or celiac disease, or slow transit constipation or pelvic floor dyssynergia. Most of these conditions which are in the differential diagnosis of IBS again are managed by a physician only. So we might change the diagnosis, but probably the patient will stay back with the physician rather than a surgical consultation.
Right. But most of these patients are, once they are labeled as IBS at one particular place, they keep moving around and probably the diagnosis keeps getting repeated. So as you said very correctly, where elderly patient is involved or where there is a lot of other symptoms coming in, weight loss and other biochemical markers or chemical changes coming along, then probably a sigmoidoscopy is warranted instead of just pulling along them with medical and drug modifications and diet modifications. Is that right?
Yeah, yeah. Perfectly. You put it absolutely perfect.
Right. Thank you so much.
Thank you, Vikram.
Thank you, Desai sir. Now the forum is open for questions. If some questions are there, those can be entertained. We have Jatkar sir with us. Girish sir, Girish Jatkar sir. Sir, are you there? Girish sir, I unmuted your mic. Please unmute it. Jatkar sir. Rahate sir. Prashant Rahate sir, if you have some questions, please.
No question. Hello?
Hello.
Hello?
Jatkar sir, good evening.
I want to give only one suggestion.
Yes, sir.
Yes, sir.
Please send the patient to counselor rather than a psychiatrist. So he will not or she will not feel bad.
Yeah, a very good suggestion, Girish sir. I mean, which we will remove the taboo. Yeah.
Yeah, definitely
Well
agree, sir. Rahate sir, you have any comments over there from your side? Rahate sir. It seems it was such an elaborate talk from Bhandarkar sir ki no questions have been left unanswered.
Yeah, it's a predominantly physician dominated field.
Yes.
So every seminar or every webinar is a learning experience, especially for the speaker, because he has to review the literature. I hope it has been the same with all of you.
Yes, sir. Yes. Thank you. Thank you very much, sir, Bhandarkar sir. As there are no further questions from the audience as
Atif
well
sir,
as.
I have
Yeah.
just one announcement to make.
Yeah.
So next week, next Saturday, we have management of choledocholithiasis. We are covering management of choledocholithiasis. Evaluation part will be covered up by Dr. Amit Agrawal sir. Evaluation and endotherapy will be covered up by Dr. Amit Agrawal sir. And
Okay.
surgical aspect of choledocholithiasis management will be covered by Dr. Shreyas Modak from Asian Institute of Gastroenterology, Hyderabad. There might be a change in that schedule if Dr. Dalvi sir confirms his talk on Saturday. Otherwise, we are going ahead with next Saturday for choledocholithiasis evaluation and management, both surgical and medical aspects. Other thing which I want to tell all the attendees is we have put up notice for next clinical meet, which is to be scheduled on second Saturday of August. So we invite all the entries from our people, from all our surgeons to present their cases in our clinical meet. That's from my side, sir. Thank you.
Okay. Thank you, Yogesh. Thank you, Prashant sir. Thank you, Neeraj Sawalake sir. Thank you, Desai sir.
Yeah,
And thank you all the
from my
audience.
side, yeah. Thank you. From my side, I would wish to thank once again Vikram, Yogesh, and Atish, and the entire Association of Surgeons of Nagpur, and all the audience for this opportunity and for this honor. Thank you very much.
Thank you. Thank you, sir. Okay. Thank you, sir.
Good night.
Good night.